Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, good morning, everyone, and welcome to the October edition of Family Medicine Grand Rounds. My name's Doug Archibald. I'm the Director of Research and Innovation for the Department of Family Medicine, and today I'm going to be the host for today's session. We have two fabulous guest speakers with us this morning, the first of which is Dr. Jennifer Young, who comes to us today from Collingwood, Ontario. And Dr. Young is a comprehensive family physician who works in Collingwood, Ontario, and her practice includes hospitalist, low-risk obstetrics, palliative care, and teaching. She works part-time as a physician for the physician advisor for the College of Family Physicians Canada as part of the Knowledge Experts and Tools group. She was on the committee of the Simplified Chronic Pain Guideline, and she is also going to be presenting an expanded version of this talk in a workshop at Family Medicine Forum in 2 weeks' time. So consider this as a bit of a primer. So Jennifer, over to you.
Thanks a lot. I'm going to share my screen and take you through a whirlwind of this presentation. And my apologies if it's going really quickly. It has to, because there's lots of stuff in there. Thanks for having me here. I am going to get this going. So the peer simplified guideline, management of chronic pain in primary care, where we're looking at osteoarthritis, neuropathic pain, and chronic low back pain. My conflicts of interest are that I am paid a part-time employee for the College of Family Physicians of Canada, and I received an honorarium to be a part of this guideline committee that created this guideline. I'm not going to take the time to read through the objectives, but the actual the guideline was published in CFP in March and is available online with all the supplements and tables, and all of the figures that I'm showing you today are available online. So please, I really encourage you to review it after the talk. This is the two-pager. Then I'll take you through the left side, which is management strategies for OA, chronic low back pain, and neuropathic pain. The right side are the adverse effects. So Canadian pain guidelines. Before this, there was some stuff on some medications, some particular indications, but not as overarching as we would like to see. So the peer group, which is a group of evidence-based medicine primary care providers, including pharmacists, family physicians, and a nurse practitioner, create these guidelines that we as family doctors can trust, ones that have no funding from industry, clinical questions that are addressed with systematic reviews, broad representation, and then respecting shared decision-making and patient values. The guidelines committee I was part of, had family docs, et cetera, it's noted there. And then the evidence team, again, majority of family docs who are evidence experts. So building this evidence base, wow, you wouldn't have believed how much they went through, looking at osteoarthritis in primary care, chronic low back pain in primary care, and then neuropathic pain. And these different systematic reviews were published at 3 different times. And so 35 systematic reviews, a lot of coffee, a lot of papers, more papers, and probably at the end for some that ended up being their work document. So we looked at responder analyses. So who gets clinically meaningfully better? So that would be 30% if somebody starts with an average pain score of 6. 30% improvement would be taking you down to 4.2. So anything to the left of that range. And so in the placebo group in this example, the placebo group moved to 40% into that clinically meaningful change, but in this example, the treatment group, 60% moved into that clinically meaningful change. So osteoarthritis was the first systematic review that looked at all of those medications and interventions. And what had enough evidence for OA? Well, what came out on top? Exercise. And what surprisingly showed minimal to no impact was acetaminophen. This is the sorts of tables that the peer group often creates. These happy face graphs that looked at each of these different interventions on the table, and what we found benefits likely exceeding harms were exercise, intra-articular steroids, and topical NSAIDs. Benefits may not exceed harms in some, so oral NSAIDs, aware that they're effective but can also cause side effects. And then duloxetine had a fair amount of evidence. Unclear benefits: glucosamine, chondroitin, visco supplementation, and no benefits, acetaminophen. And then in this red, where the harms likely exceed benefits, no surprise, opioids. Well, I hope no surprise. So opioids and osteoarthritis, this systematic review looked at that's good to 4 weeks perhaps, but not beyond. And then opioids do not work more than placebo for chronic pain in osteoarthritis at greater than 4 weeks. So there's the 4-week number. And here's the metagraph that shows essentially no improvement. Chronic low back pain, systematic review, medications, interventions, what had enough evidence, lo and behold, exercise comes out on top once again. So exercise really is not just an add-on, it is the primary therapy for both of these conditions. Corticosteroid injections did not show benefits. Of note, these are epidural and not the facet joint. We didn't find enough evidence on facet joint injections to make a statement about it. These were epidural steroid injections. I want to take you through the study of impact, the study of quality on treatment effectiveness, and this is in chronic low back pain. The bottom line of this along the bottom at the 0 is what placebo achieved, and anything above that line is what the intervention achieved. On the left is the increase in improvements. So the big blue dot is all studies combined. And if you then look at, as example, with acupuncture, the big blue dot shows 23% improvement. If you start to tease it out into quality features, the little purple dot is publicly funded trials. if the little gray dot, which remains statistically significant, so that little circle, it stays a circle if it's still significant, it becomes an X if it's not significant. So sham controlled studies showed a 10% increase, but the other longer studies, larger studies, lower risk of bias, didn't end up showing improvement. This is spinal manipulation, where the improvement at 22% is all of these interventions stay significant, but reduce as we look into larger, longer studies. And then rubifacients, so capsaicin, that there were no publicly funded studies, no studies more than 3 weeks, and this is chronic pain, so you got to have something for more than 3 weeks to call it chronic. That's what we found in that intervention. So with chronic low back pain, again, we'll have a look at these graphs. Oral NSAIDs, as an example, all of these dots, 42% did not improve, 40% improved with placebo, and 18% in addition, so 58% improved on oral NSAIDs. That's the sort of the structure of those little happy face graphs. Again, benefits likely exceeding harms, exercise and spinal manipulation. Oral NSAIDs were in this benefits may not exceed harms just due to their side effects. Corticosteroids showed no benefit. Unclear with acupuncture and rubifacients, and harms likely exceed benefits. Again, we're looking at opioids. So these are an analysis of the opioid studies. Low quality studies showed some effect, higher qualities, no effect. Neuropathic pain, systematic review, exercise, acupuncture, rubifacients, topical lidocaine, anticonvulsants. So what had enough evidence? It was the gabapentinoids. So gabapentin and pregabalin were the two that were mainly studied, and they were equivalent. And of the SNRIs, duloxetine was most studied, and there was no difference between duloxetine and venlafaxine. An interesting note about tricyclics, and we've probably often, all of you, used tricyclines for chronic, for neuropathic pain. Very low evidence, very low quality of evidence. And when we looked at the responder analysis, we didn't find many studies in that. But when we broadened the criteria for beyond responder analysis, looking at pain scales, there was a number needed to treat of around 5 or 6. So we're a little uncertain whether tricyclics really could have a beneficial effect. Opioids showed some possible effect, but again, the number needed to harm was lower, i.e. more people were harmed than were helped in the opioid group. So neuropathic, gabapentinoids, SNRIs, and rubifacients. No benefit with acupuncture, and unclear benefits, tricyclics, and benefits may not. Also opioids, that was there was some positive effect, but the number needed to harm again was lower than that to treat. Exercise and meaningful pain relief. Really pretty solid. When you look at the metagraph, they are all on that, they all have on the right side of effect. So most common exercises were physio guided, others were yoga, Pilates, Tai Chi, Nordic walking. And so our recommendation is that we recommend the discussion of physical activity as the foundation for managing OA and chronic low back pain. What type? Anything they'll do. For example, we came across dancing with cats. Well, if that's what someone's going to do, then just encourage it. Psychological therapies. 5 RCTs reported clinical meaningful change. So one of them being, for example, a reduction in pain bothersomeness. Another, patients who considered themselves recovered, and pretty robust results. 48 versus 31%, 59 versus 31. Now, keeping in mind that we know that this sort of access is difficult, we didn't want to come out and say you must do this, because we know resources do not always make that available, but we do suggest a discussion of this as options if when services allow. So opioids, again, summary, osteoarthritis, no benefit past 4 weeks. Adverse effects are greater, low back pain, no benefit in high quality studies, stop due to adverse effects. Neuropathic pain, perhaps a benefit over placebo, but stopping due to adverse effects, 14 versus 6%. And so on the whole, we suggest treatments where harms likely exceed benefits be avoided in most patients. So this was a 2-year journey, bringing it all together. That's what we came up with. And to zoom in on these on this box, you've got evidence with clear treatments with clear evidence of benefits, and that little teal line, it's 100%. The full teal line is 100%, and the darker teal is the component where the intervention helps. And in the top, you see that the placebo in osteoarthritis helps 40%, 40% in low back pain, and 30% in neuropathic, 29% in neuropathic pain. And then the interventions below show their increase in benefits. So we've got unclear benefits. That's what our outcome those were our recommendations. I won't read them out loud. And so we had actually, in addition to all that, we asked the evidence team, to look at a few other questions that were the guideline group wanted them to answer, and they did further evidence review. And I'll just put these up here. So, can interventions in acute pain prevent chronic pain? No evidence for that. Is exercise effective for chronic neuropathic pain? It's unclear. How can we encourage physical activity? Activity trackers and an exercise script help. What is the best type of exercise? Anything the patient will do. Are psychological strategies effective? Yes, as we've gone over. Are cannabinoids effective for chronic non-cancer pain? Likely yes for neuropathic, but the studies are tiny. It's amazing how few studies there are, good studies in cannabinoids. So the other questions are: tricyclics effective for OA and chronic low back pain? Back pain, probably. Osteoarthritis, not clear. Does combination therapy improve more than mono? And we suggest the addition of another med can be discussed if the initial med has been partially beneficial, but stop something that isn't helping. Why have a medication you don't need? Are topical TCAs, nitrates, ketamine, muscle relaxants, or combinations effective? Unclear or no benefit. If someone's on opioids, does pain or function improve if their opioid dose is reduced or tapered off? And our findings were: if a patient is on opioids with no opioid use disorder, suggest discussion of slow reductions supported by CBT if possible. The best evidence, though, is of harm if people are not interested in tapering opioids. So it's definitely a shared discussion, and as you know, a very a slow process, one that is that takes time and needs a willing patient. And then this final question: will diet-induced weight loss reduce OA knee pain in obese adults? And it's really unclear. What seems to be the best effect is moving, not necessarily the weight loss. So get your patients moving. They don't have to lose weight for them to have an improvement in their pain. So some resources that we have recommended in the guideline. This is a 5-minute video called Tame the Beast. It's a great video. That there's a website called Gentle Movement at Home, which is what it says it is. Andrea Furlan has tons of videos on chronic pain, some theory behind it, but also specific exercises for specific pain conditions. And here's the example from RX Files, the physical activity, and this dovetails nicely into the next talk. This is a pain calculator. I won't go into how you use it, but you can have it with your patient around discussing treatments. And this is the patient pamphlet that we created that summarized many of the ideas that I've just discussed. So the committee members, thank you for hoping that you find this a very useful resource that you will put on your desktop to have for your discussions with your patients. And the peer newsletter is one that can give you, signing up to that gives you access to updated information of the activities that we're doing. Right now we're working on updating the lipid guideline, and we're the group that puts out every 2 weeks the tools for practice.
Jennifer, thank you so much. That was a very informative presentation. Very much appreciated. So big thank you to you and to the peer group, and look forward to your session at Family Medicine Forum. I'm now going to introduce our next speaker, no stranger to us in our research community of practice. This is Dr. Patricia Huston, a family and public health physician who works in the areas of emerging infectious diseases at the Public Health Agency of Canada, and is affiliated with the University of Ottawa's Department of Family Medicine. And her research interests are in low-grade inflammation and chronic disease prevention. So Trish, over to you. Oh, you're muted.
There we go. I am really happy to be here today. And I have a lot of new stuff, and a lot of it is quite technical, getting down to cellular processes in our microenvironment. But I hope to make it entertaining in a way. And my goal is to actually inspire you about the importance of a healthy lifestyle. And I will just reiterate that, yeah, I think exercise, physical activity is actually the foundation of a healthy lifestyle. So there is a nice thread that goes through these two talks. I have no conflicts of interest to declare. And so I'll just go to my shared screen. So have you ever wondered how an unhealthy lifestyle increases the risk of chronic disease? Now, a lot of this information I'm going to go over today may be new to you. It certainly was to me before I started researching this question. And like Jennifer, I just want to preface that I could have easily talked for an hour. And so a lot of the details are gone, and I have tried to really get to the heart of the matter. So first of all, just burden of illness. Chronic disease exacts a huge toll. It has been referred to as a silent epidemic. And during the height of COVID in 2020, chronic disease killed 4 times more people than COVID. We're talking about heart disease, stroke, diabetes, chronic lung disease, Alzheimer's. And this accounts for about 90% of our healthcare dollars in terms of hospitalization, physician time, medications, and so on. And yet, these diseases remain unchanged in the top 10 causes of death for decades. Like, we really haven't been able to make these diseases budge. Now, we've known for a couple of decades now that chronic disease progression is associated with low-grade inflammation and increased inflammatory cytokines, and that this is linked to an unhealthy lifestyle. But what is less clear is, like, how does an unhealthy lifestyle increase cytokines? And how do cytokines cause chronic disease progression? Okay, so I did something that's called a network analysis. And this is the study of interactions of components of complex processes. I'm really going to zero in on just a couple of the levels here between lifestyle and the microenvironment. And I want to bring this alive because I know when you start talking about phenotypes of macrophages that people's eyes can glaze over. So I want to bring this alive by telling a story, a drama actually. And, you know, maybe we should think of these cells as intelligent life forms, which in fact they are. And think of the microenvironment as the planet on which they live. So here's the drama. The setting is the microenvironment. And in this microenvironment are the parenchymal or organ-specific cells. The main character are macrophages and fibroblasts, and you'll be introduced to them shortly. And we've got an opening scene that leads to the answer to question 1, the connection between lifestyle and inflammation. And then the drama, how things go awry, and the answer to question 2, So the connection between inflammation and chronic disease. So what we have, two main characters, two questions, and basically a two-act play. Now here's the setting. This is an artistic rendition of the microenvironment. And the microenvironment is part of the whole body interstitium, which is a microscopic web-like structure that permeates all tissues and organs and provides support and structure for the parenchymal cells, for the organs and tissues. Now, the main part of this is the extracellular matrix. That's what provides the web, if you will, and the support. And this was once thought to be inert, but it is now known to be this dynamic, fluid-filled structure. So you can see there's the vertical capillary here going through, and it is what releases fluid into the interstitial space. And it circulates through there. And then you can see on the right that it is absorbed by the lymphatic vessel. And so it goes through the lymphatic system and empties into the venous system. And then, so there's a bit of a circulation. You'll see these purple star-like structures are the macrophage. At the bottom near the right is a fibroblast. And there are other cells that can vary by location. So here we are in Act 1. Now, the first thing that happens is a parenchymal cell dies. And this could be due to just simple senescence, that cells don't last forever, and they release something called SASPs, or they get damaged, like perhaps there was an episode of angina or something like that. We're going to be using the heart as an example in some of these things. And so it didn't get enough oxygen for a while, and so it released something called damage-associated molecular patterns into this interstitial fluid. So then what happens? Well, meet the main character of this play, the macrophage. Now, the macrophage, he's really the hero of this story. But the secret about him is that sometimes he can also be a tragic villain. Now, we know the macrophage is part of the innate immune system. When I went to medical school, I thought, yeah, it circulates in the blood and it eats microbes. And that's true, but it's more than that. So it turns out that there are resident macrophages that reside in the microenvironments of all organs and tissues. And they're actually formed, it's part of the embryogenesis, it's formed in utero, that you're born with these resident macrophages everywhere. Now, the job of our hero is to deal with threats. So they do detect and eat microbes. They also orchestrate the normal healing and repair process. But when they get dysregulated, they can contribute to chronic disease progression. So you may wonder, oh my goodness, how could they possibly do all that? Well, it turns out that macrophages have different phenotypes, different expressions or forms of cellular behavior. And they've been called simply M0, M1, and M2. Now, it turns out that these different phenotypes map on very closely to the normal stages of the repair and healing process. So let's start with M0, and that's this surveillance mode. And during surveillance, the macrophage is kind of walking along, checking everything out. Let's see what's happening. And then when they see some damps or some dead cells or a broken blood vessel or something like that, they immediately switch into action, into M1, the inflammatory mode. And one of the things they do is they basically say, okay, let's call in some backup here and clean up. And they actually call in other macrophages from the bloodstream, as well as leukocytes and other cells to help with the cleanup. And then when everything's cleaned up, they assist with the repair process. So maybe the stem cells come into action to create new cells, or endothelial cells help with the new vessel formation. And it's really like supporting the construction. Now you may be saying like, this is getting really a little bit too theatrical. How do they actually say that? Well, macrophage produce cytokines. And in fact, cytokines is how macrophages communicate. Cytokines are signaling molecules. And so when a macrophage is saying, let's attack and clean up, they are actually pumping out pro-inflammatory cytokines. And when the macrophage is saying, hey, let's help get back to normal, they are secreting anti-inflammatory cytokines. And this is actually called intracellular crosstalk in the literature. So, how does an unhealthy lifestyle increase inflammatory cytokines? Well, the gut is lined with about 1 million resident macrophages. And so if you have unhealthy food and are sedentary, it actually fosters an unhealthy microbiome, which stimulate these macrophages to release pro-inflammatory cytokines. On the other hand, if you have healthy food and regular physical activity, it fosters a healthy microbiome, and the macrophages start releasing anti-inflammatory cytokines. Now, these cytokines are always released locally in the microenvironment, not just from macrophages, but others, but it gets into the systemic circulation. Now, there are other sources of cytokines. So if you eat too much and have fat cells, they release adipokines. And that is a pro-inflammatory cytokine as well. The good news is that your muscles, when they're exercised and stretched, they release myokines, which are anti-inflammatory cytokines. So there's this whole conversation that's going on in our body among ourselves. And you can measure cytokines in your bloodstream. Perhaps some of you have. The most common measure is C-reactive protein. Now, what about stress? The autonomic nervous system also affects macrophages. So if you're under chronic stress, anxiety, bullying, or experience social isolation, and we heard a number of months ago about the effect of social isolation on our health, it stimulates the release of norepinephrine that binds to the receptors of macrophages. And this amplifies the release of pro-inflammatory cytokines. The good news is if you have good social experiences, like these talks today, or relaxing exercises like yoga and Tai Chi and so on, it stimulates a parasympathetic response. And there have been studies that have documented this through heart rate variability. And it has a buffering effect on stress. And so the more anti-inflammatory cytokines can prevail. So the answer to question 1, an unhealthy lifestyle increases cytokines through a poor diet and macrophages lining the gut, through sedentariness, because you lose the moderating effect of your anti-inflammatory myokines, and through stress when sympathetic overload stimulates these inflammatory macrophages to release more inflammatory cytokines. So that's the end of Act 1. And Act 2. So what is the connection between cytokines and chronic disease? So meet our second main character, the fabulous fibroblast. Now the thing is, she is the macrophage's partner. She's a connective tissue cell that maintains the extracellular matrix in the microenvironment. But her secret is that although most of the time she's fabulous, sometimes she can be a femme fatale. Now, fibroblasts act in lockstep with the macrophages. So when the macrophage is in surveillance mode, the fibroblast is in maintenance mode. And so it's taking care of the matrix, supporting stem cell niches, and everything is hunky-dory. When the macrophage goes into inflammatory mode, the fibroblast starts pumping out extracellular matrix. So if you have a heart attack, for example, the first thing the fibroblasts do is try and contain the damage by just pumping, surrounding it with this fibrin extracellular matrix to contain the damage. But it also releases pro-inflammatory cytokines. Now, when everything calms down and recovery begins, the fibroblasts also assist with the repair process. And then there's a remodeling phase where the extracellular matrix realigns. So what's the link between cytokines and chronic disease progression? Well, here's the linchpin of the whole talk. Chronic disease progression occurs when the three-phase healing process gets stuck in M1, in this inflammatory mode. It never gets to the M2 healing and repair mode. And this happens when there are repetitive conditions, chronic insults that recurrently stimulate the macrophage into an M1 phenotype. And this is precisely what occurs with an unhealthy lifestyle. And this has been linked to diabetes, kidney failure, cardiovascular disease, COPD, arthritis, the whole shebang. And then a vicious cycle ensues where the macrophage in M1 keeps stimulating the fibroblasts until they dysregulate and all they do are in the inflammatory mode. And that leads to increased tissue stiffness. So for the heart, that's when you start developing heart failure, and it's just the heart isn't able to pump as well. The increased tissue stiffness stimulates the macrophages, and they become dysregulated, and all they can do is M1 now. They can't cycle through the larger cycle. And then chronic inflammation and fibrosis progressively destroys the parenchymal or organ cells and leads to loss of function. And it turns out that fibrosis is the hallmark of end-stage chronic disease. And I never really thought about it before because, usually you study one organ at a time, right? And here's what happens with heart disease. And in the end, PS fibrosis. And here's what happens in lung disease and PS fibrosis. And you never really realize that fibrosis has become this common horizontal theme across all end-stage chronic diseases. And currently, there's no treatment. So what is the epilogue? This is the summary and a bit of a discussion. So an unhealthy lifestyle stimulates the release of cytokines from resident macrophages. And because it's repetitive, this leads to low-grade inflammation. But when macrophages do this, their partner, the fibroblasts, do too. And this is what leads to a vicious cycle of inflammation and fibrosis that eventually destroys your cardiomyocyte, your hepatocyte, and so on. Now, understanding the microenvironment in chronic disease is a new frontier. Actually, if you go to PubMed and do microenvironment cancer, you will get over 6,000 hits. But when you do microenvironment in chronic disease, there aren't quite as many, but there's going to be more. Now, I published my paper in July. This just came out last month in Science. It was called The Microenvironment in the Heart, a Coalition to Heal. And it says interactions between cell types in the heart are essential for the coordinated function of the heart. And here you see, if you start on the left, the immune cells, the cytokines, the DAMPs that we talked about. You've got your cardiac cells, your fibroblasts. This article points out that there are actually more fibroblasts in the heart than cardiomyocytes. And then there's the matrix, lymphatics, the vessels, and then the senescence that we talked about, and the SASPs that are released into that microenvironment. Now, like I said, this is early days. There's much more we need to know. This theory explains chronic disease progression. It does not explain chronic disease etiology, like what caused that cell, that cardiomyocyte, to die in the first place. We do not completely understand the interactions either between the local and systemic sources of cytokines and how they interact. But you can imagine, if you've got a lot of local inflammatory cytokines in your knee, that cytokines coming out of the bloodstream flowing through your microenvironment doesn't help either. And we don't always know why inflammation settles into one organ versus another, except for this theory of repetitive insults. So I think this is the start of a new chapter in CD management. Fibrosis, in a recent New England Journal of Medicine article, was called one of the major causes of death worldwide. And again, it's because it's this common theme that goes across all these different chronic diseases that are in the top causes of death. The good news is the first macrophage modifying medication has been approved for the treatment of diabetic foot ulcers. And what an excellent example that is of a stalled healing process. You want to get that macrophage to go into M2. And the first treatment for fibrosis is under development. And interestingly enough, this uses technology from mRNA vaccines to target and destroy myocardial fibroblasts that are responsible for a lot of the heart failure that eventually occurs. Now, whenever we start to understand the mechanism of the disease, the first impulse is to say, hey, we could interfere in this mechanism with a new drug. And so there is a lot of research underway in new drug development that looks at exactly what's happening in the microenvironment. And the same has happened for cancer. In fact, there are new cancer treatments that utilize this knowledge of the microenvironment. But this should not sway us away from the importance of lifestyle that can actually prevent all chronic diseases. So again, my hope for you is that understanding the biology of this will actually inspire you to see the new importance of lifestyle. It's often been a kind of, I'll kind of do that when I get retired. I don't really have time for it now. And, it's a nice to have, it's not a must have, but actually how you treat yourself and your lifestyle affects your very cells. So my wish for you is that this will inspire you to recommit to eat well, stay active, cultivate your connections, and then all the microenvironments in your body will thank you. Thank you very much.
And thank you, Trish, for this screenplay drama in the microenvironment. Very creative. Thank you so much for sharing. Something that I thought earlier on in your presentation, Trish, was, I was thinking of like warning labels. Is there anything more like on unhealthy food, for example? I know there was some talk, in public health circles around this, much like has been done for cigarettes and so on, around this. I mean, you're giving the explanation as to why things are unhealthy, but that was just something that came to my mind.
That's a great point. I know that one thing that has been done, and this was through Health Canada, is they've started to insist that at least you put the calories of foods in restaurants. And, there often is the label as well, talking about calories and number of, grams of fat and all these kind of things. But I think a warning label could be a good idea. But the other thing is that like on an exercise program, they should say, and by the way, this is actually could be the most important thing you could do for your longevity, you know? And
yeah, the positive messaging. Yeah, exactly.
Yeah.
Jennifer, Trish, thank you so much for your presentations today.
Yeah.
And look forward to seeing you next month, everybody. I believe it's the Briere Family Health team that is going to be presenting. So till then,